separated patients into three big pools. One pool is the patients who have acute kidney injury, who have worsening kidney function or have suboptimal kidney function. And then there is the pool patients with stable kidney function, but they are high risk, high immunological risk for rejection. And then there are the patients who are with stable kidney function but do not fulfill the criteria of high risk. And based on each pool, we have a separate screening protocol.
Oh, perfect. Hi, I'm Hajjiri. I'm a transplant nephrologist and the Senior Medical Director of Organ Health and Transplantation here at Natera. We are honored to have Dr. Zahraa Hajjiri, Assistant Professor in Medicine and the Medical Director of Kidney Transplant Program at University of Illinois at Chicago. She's going to share her experience about using Prospera in monitoring her patient. They have a protocol in their program and they categorize patients in different categories: low immunologic risk, high immunologic risk, and the people who develop an acute kidney injury. I hope you enjoyed this episode and we're going to all learn from her experience. Welcome, Dr. Hajjiri. Thanks for being with us today.
Thank you. Thank you for having me.
Let us know about your program. How do you monitor your patients? How things going on in your center?
So UIC is one of the largest programs nationwide. We do about 260 to 300 kidney, pancreas a year. And we're known for spearheading the high-risk patient population, morbidly obese, cross-match positive. And having a biomarker protocol that would help us monitor and risk stratify this patient population does help us identify patients who would require a biopsy or just a screening for now. So initially our protocol or our workflow was to get monthly testing for donor-derived cell-free DNA or Prospera and DSAs. And it helped us identify patients who are at a higher risk to develop complications such as rejection. We're getting a more comprehensive clinical picture than just a single value. So getting multiple values in patients with high risk and a stable kidney function gave us more information onto whether this person has an ongoing injury or not.
Very interesting. So tell me a little bit more about your protocol, and did the recent publication of donor-derived cell-free DNA, the data which has been published, did it help you to come up with whatever you're doing right now?
We separated patients into three big pools. One pool is the patients who have acute kidney injury, who have worsening kidney function or have suboptimal kidney function. And then there is the pool patients with stable kidney function, but they are high risk, high immunological risk for rejection. And then there are the patients who are with stable kidney function, but do not fulfill the criteria of high risk. And based on each pool, we have a separate screening protocol.
Oh, perfect. So pretty much you have AKI patient for cause patient that they have something you're worried about rejection happening right now. And then you have patients who their kidney function looks good, but you categorize that in two categories, the one which is low risk immunologically and the one which is high risk immunologically.
That's correct.
Tell me more about your high risk immunologic group.
So high risk are the patients who are either cross-match positive or ABO incompatible or have donor-specific antibodies, what we call DSAs, either de novo, new post-transplant, or they had pre-transplant DSAs. And there are patients that we have made significant changes to their immunosuppression, such as an addition of a belatacept agent, or switching one drug with another, or minimizing immunosuppression due to recurrent infection or particular opportunistic infection or malignancy. So these patients, because I always tell, we're rocking the boat. We've been at a stable state for a while, and then all of a sudden we rock the boat with changes of immunosuppression. So we need to see, hey, how is the body reacting to this change before ending with an AKI? I don't want to end up in an AKI. I don't want to end up in an AKI in a patient whom I'm preparing for pregnancy, right? I'm making changes. The person's not pregnant yet. Will they tolerate this drug? I want to see, after making these changes, what's going on before the AKI occurs. So these high-risk patient population get more frequent monitoring with the Prospera.
How frequent?
So patients within the first year post-transplant, they typically get one at 4 weeks, and then they get one at 8 weeks post-transplant, and then 16 weeks post-transplant. And then they get one at 7, 9, and 11
months.
So 7, 9, and 11 months post-transplant. So it's about 6 values in the first year, and we did it at specific time points to guide us in changing immunosuppression.
So this is for your high-risk group.
Yes.
How do you do for your stable patient who are not considered high risk?
So stable patients, or the low-risk patient population with stable kidney function, we still monitor them as frequently as the high risk the first 3 to 4 months, because that's the stage of the highest risk of rejection. The past 6 months, we kind of slightly go down. We do it maybe at 7 and 11 months post-transplant. Unless they start developing any other complication, we switch back to the high risk frequency. So those are the stable patients with low risk.
Tell me about the time points that you decided to do that.
So 4 weeks is 4 weeks. It's a baseline. I'd like to see, after the reperfusion injury, I'd like to see where am I at in regards to a donor-derived cell-free DNA. And then I get another one 4 weeks later. Sometimes it's a little high because there is still remnants of ATN past the 1 month, and I'd like to see a drop in it at 8 weeks. If there is no drop at 8 weeks, I get concerned. Plus, if I see a rise at 8 weeks, this is the time where I start minimizing, reducing tacrolimus trough. This is the 60 days or around the 60-day cutoff where our tacrolimus troughs start to go down from 8 to 12 to 5 to 7. And hey, is the Prospera is elevated, or I see an increase from 4 to 8 weeks, I'm going to start thinking maybe I should do a biopsy early on to rule out a rejection, a subclinical rejection, before I go down on the medications, rather than waiting until 12 weeks post-transplant.
Right. In your center, do you guys do steroid-free?
Yes, we're majority of our patients are steroid-free.
Okay. Do you monitor them differently from the patients who are on a steroid?
No, they're both monitored. But I will say this: our patients who are on steroids, they're on steroids for a reason. They're on steroids because they're either cross-match positive, they're on belatacept. So the majority of our steroid patients would automatically fit in the high-risk patient population because they needed a higher level of immunosuppression to start with because of their baseline immunological risk.
And one of the other topics that people talk about, when you talk about the high-risk group, do you put the patients with any high Prospera level in that high-risk group?
So once we see a high Prospera that's alarming, we biopsy the patient. And if the biopsy shows rejection or any sort of allogenic reaction or inflammation, so we switch them to the high-risk group because we're going to treat that rejection. They become a high-risk patient, part of the high-risk patient population, and they are monitored differently. They'll have more sequential monitoring after the therapy of the rejection to see, hey, has the rejection been treated? Because there is data that shows that, and there is data is actually published in the ATC, that after a biopsy, and you treat the biopsy, you see a drop in the Prospera, and you should see a drop in Prospera. And if you don't, then there's something else going on, and you may need to rebiopsy that kidney.
Okay, very good. So you brought up another question.
Yeah.
Do you see the value of serial monitoring of the Prospera to evaluate the response to the treatment when you treat the rejection?
So we like to see a drop in the Prospera back to baseline or back to negative level with the therapy, but we would still biopsy the patient to make sure that there is resolution of rejection histopathologically.
So now that we talk about surveillance in the patient, high risk and low risk, how do you deal with the patient with acute kidney injury?
We get a Prospera, and based on the result and based on other values, such as, hey, did he miss any medications? Are there any DSAs? Has there been any lower FK levels? And then based on the information, we biopsy, or based on other test results, we may watch and say, hey, maybe this is just a ATN or transplant pyelo. Let's just monitor it afterwards and see what it is. So the majority of the patients get biopsied, especially within the first year.
So when the patient developed the AKI, and regarding the surveillance after they resolved that AKI, do they go to your high-risk group regarding the frequency of the times that you do the testing on them?
If the biopsy shows rejection, yes, they'll go to the high-risk surveillance group. The biopsy shows no evidence of rejection, they will remain where they are.
Okay, great. Have you used our ProReach program, which is a mobile phlebotomy, and did it help you?
Yes. So ProReach is technically, and I will say this is you provide a service where there is a phlebotomist that goes to someone's home, and they not only do the Prospera, but they also do the routine labs, and it has been quite significant and helpful. So I do a lot of outreach. So I cover a large diameter in Illinois, and it's hard to find a lab that would do some specific tests. And also COVID happened. So this particular service has helped my patients in other locations such as Rockford, where phlebotomists would go to the home and draw blood work, including donor-specific antibodies, the Prospera, and some basic labs. And some patients, they have transportation issues and they can't really move around. They need to get transportation, someone to drop me off, pick me up. So that has helped quite a bit for our patient population.
And since you have a great experience using your protocol monitoring your patients in such a large volume center, tell us about an interesting case that you had.
So it was just recently. So I had this patient, she's young, she had a history of lupus, FSGS, and she developed some AKI early post-transplant, maybe the first 2 weeks, and that AKI showed that there's TMA. We thought the TMA is related to other process. It wasn't AMR then, so she was placed on a large, higher level of anti-rejection medicine. So then we placed her on prednisone, tacrolimus, mycophenolate. We thought the TMA could be related to her CNIs or the tacrolimus. So we started also eculizumab and belatacept, hoping that we can replace the belatacept with eventually tacrolimus. So she was also an anticoagulation for a DVT and a PE. She did quite well. So her creatinine went all the way down to 1.1, and she was doing great. She started developing some DSAs, and despite being on that level of anti-rejection medicines. And then I was doing Prospera on her monthly. I was outside the protocol because I wanted to make sure that, hey, I'm not missing anything. And her Prospera never reached the 1% limit. But it was like, you're looking at, I don't remember exact value, but it was like a 0.4, 0.5, 0.7, and I'm like, there's something going on there. And to admit her with a history of a PE, to biopsy her, with a history of PE, I got to bring her in, put her on heparin, because I really don't want to stop anticoagulation on someone who's at risk to clot. So I did that, and I did biopsy her, and her biopsy showed a severe cellular rejection. So she had a 1B and a 2B. So she had intimal arteritis and acute tubulitis, which was quite significant, and it requires admission for 5-day thymoglobulin therapy. So that's not the first case. We see subclinical AMRs with a slow rise in the serum creatinine, a slow rise in Prospera, and it's still below the 1%. And that's why I always stress to my colleagues, listen, it's not only about the number, it's about the trend of the number. Because it's if there is ongoing injury, even if it's minute, you'll see a slow rise in the serum creatinine. You'll see a slow rise in the Prospera. But if it's an ATN or something else, it won't be a slow rise. It's a single insult. And theoretically, after the insult is gone, you should start seeing a decrease in the level.
Yeah. That's very aligned with the proactive publication that we had.
Yes.
That we showed that it's a rise in the Prospera level months prior to the biopsy-proven rejection, which for ABMR was up to 5 months prior, and the TCMR 2 months prior, exactly as your experience.
Right.
I'm glad there is a live example of how that helped the physicians.
Right.
What is your message to the patients?
Transplant is hard. Taking care of an organ is hard, and it's a responsibility. And we trust you with that responsibility because kidneys don't grow on trees. We trust that you're going to take care of that organ, and you're going to take your medications. And as a center and as a transplant community, we're here for you. We're here to help you. You're not in this journey on your own. I think this is very important for a transplant patient to know. They're not in it on their own. They should not be trying to answer questions on their own. I always tell patients when they're being evaluated, there's an army out there. This is not a one-man's band. There's an army out there who has every single aspect of your care covered. Make use of that.
Dr. Hajjiri, thank you very much for your time and sharing your experience with us. We learned so much from that.
Thank you. Thank you for having me. It was such a good experience. Thank you.
I hope you enjoyed this interesting conversation with Dr. Hajjiri from University of Illinois at Chicago. If you like this episode, please subscribe and see the other episode regarding other issues with kidney transplant using Prospera.